You've asked me to speak about China and about myself. Well, we don't normally speak about ourselves in Britain, but as a Welshman I unhesitatingly do, in the recent context, of course. Now, first about China. Now, what is the evidence that China is engaged in neo-imperialism, which is what you asked me to talk about? And I'm going to read what I have to say on this. In 1990, the BRIC countries accounted for 1% of African trade. Now it is 20, and by 2030 it will be 50%. China is now Africa's biggest trading partner. Its loans exceed the loans of the World Bank and are more than the combined loans of the European Union and the United States. Last year, China made $3 billion available for infrastructure, roads and dams, and for basic services, health and education. China made $6 billion available for Congo, that troubled jewel giant that straddles the equator, bewitches journalists and provided Graham Greene and Conrad with the stuff of wonderful novels, which I hope you've read. These dollars were through a private company, however, and so were not subject to careful transparency. The money will be used for infrastructure. Much will be for roads for the extractive industry, and will be set against $6 billion worth of Congolese minerals needed for Chinese industry. China was the first country to develop a special economic zone in Central Africa. In 2006, when it built the 1,860 kilometers of the THET railway for Zambia. This railway enables landlocked Zambia to export its copper to Dar es Salaam. Copper accounts for half of Zambia's GDP. Copper is critical for China's technical manufacturers. Is this neo-imperialism? No, it is straightforward mercantilism. It belongs in the lexicon of globalization, not of colonization. The factories of southeast China will fall silent if the night howls of the hyena and the crackle of the crickets in the East African night bush are not disturbed by the clatter and the whistle of the train as it chugs up into the interior. The FT, in a series of reports on China in Africa, stated that the West cannot compete with China's pragmatism, determination, work ethic, and long-term vision. But nor can many people in African countries, in towns and villages. If Chinese involvement in Africa is analyzed economically, it is mercantilism. But it may not be perceived thus, and there is much misunderstanding. Let me give you some examples. An old friend of mine in Malawi, I wrote to him about this when you asked me to write. He talks about the problem of cheap Chinese goods flooding the local market. And there also seems to be two possibly incompatible worries by local people about this, that the goods are almost synonymous with poor quality, and people resent the fact because they feel that these are being dumped rather than challenged into more advanced markets. And secondly, that this flooding is stifling local enterprise, stealing local market, and so local entrepreneurs are undercut and outcompeted. My friend continued that on the larger scale of the big roads, people are delighted. Then they wonder, China seemed to be active and involved, active but not involved. My friend was told that when in Malawi they live apart, not mixing socially. And one said, I don't really know what's in it for them. What's their agenda? There obviously is an agenda. We just don't know what it is. Secondly, a friend in Lusaka, to whom I wrote, said that there is not very much integration and there are considerable tensions between Zambians and Chinese. She said that stories of Chinese factory owners not paying workers minimum wages or workers striking for better working conditions are common in the newspapers. Finally, I witnessed this clash of cultures myself in Ethiopia last year. A new road was being cut through hills and raised over valleys to replace or bypass the original paved road built during the Italian presence 70 years ago. It had a large, gated, barbed wire camp of many, many temporary dormitories for Chinese workers. Far from the nearest town, and, although appropriate for its task, far from any cohesion of culture. In my hotel, a Chinese team was equally isolated. The men disappeared in the early morning, came back in the evening, disappeared into their rooms. That road is essential for health care and development, if only it could also be used as a road toward mutual understanding. Now, you've asked me to say what I have contributed to public health in Africa. Well, as I'm a bedside clinician, I really take that as quite a compliment. Thank you. So I'll say, just to give you a few illustrations. In the last days of the colonial regime, the British government built a wonderful teaching hospital at University College Hospital, Ibadan, Nigeria. When I worked there at and after Nigerian independence, and you can see the Nigerian flag is draped round the building for the independence celebrations in 1960. One of my friends was Professor Adetokunbo Lucas, an outstanding public health physician, and we were senior registrars there together. He made an indelible mark on tropical medicine when he established the Tropical Disease Research Program for WHO in Geneva. Less than 20 years later, Lucas and I, from a balcony of the third floor of this hospital, which you can see there, looked out over the great city of Ibadan, with its thousands of corrugated roofs, jumbled together in a benign chaos, where its million and more people live, overcrowded, crammed together, with poor hygiene and a shelter for disadvantaged urban migrants. Lucas said, "This hospital has made absolutely no difference to the health of those people over there." Now, lots of good research and papers had been published from Ibadan, and yet the hospital had a hospital focus within a biomedical model of healthcare. Necessary but wanting, desirable but deficient. When Lucas and I spoke, it was just about the time when I was finishing my time as professor of medicine in Zaria in northern Nigeria, where I'd been for 8.5 years. And in Zaria, we had tried to relate the patient in the bed to the community outside. Oxfam gave us a Peugeot pickup, which we took round to the local market, and a chap knocked it up and put a roof on it and the sides and windows and some seats inside so students could be cattled inside. And we'd take them out into the bush. I would take them into the bush on a Friday afternoon to see how their patients lived, so that the urban privileged could go to the homes of the rural poor, to see the crops they grew, to find out, for example, how much a patient's cash income had fallen as a result of their disease. One man told us that since his tuberculosis had laid him low, his wife had tried to manage his few crops. Their annual income had fallen from £55, this was before the naira was introduced, to about 37, which he couldn't support his family and children on. Was this clinical medicine or public health? We were training physicians for Nigeria, not for Minneapolis or Manchester, so that we had to look laterally. We did not talk about the social determinants of disease then, rather we were confronted by them every day. We realized that truly academic medicine, or an honest, relevant medical education, could not divorce the community from the clinical. And as head of medicine, I wanted my colleagues to do the same. They were exceptional people who fieldwork in the department was taken as the normal and was taken a stage further by Professor David Worrell, who revolutionized the analysis and approach to snakebite, by Anthony Bryson in onchocerciasis and leprosy, by Hilton Wilton in sleeping sickness, and by Hilton and Brian Greenwood in meningococcal meningitis, all neglected them. And Brian, on his work for meningococcal meningitis and much else, led him to his FRS, his knighthood, and only last week to the Gardner Medal for Global Health. It's nice when a head of department sees his juniors go above. Zaria led to Ilorin, where I had been asked by another distinguished Nigerian physician, Eldryd Parry, to establish a new medical school. Together we wanted to prepare doctors for rural and urban Nigeria. We must have done something right, because the school was soon recognized as a WHO collaborating center for innovative medical education. And we had a program called COBES, Community-Based Experience and Service, in which we involved all the members of the faculty in community work. As dean, I could tell them what they had to do, and surgeons and chemical pathologists went and lived in the field. And we lived with them at the beginning of the first year in the field, which transformed their attitude towards the community. My village, where I lived with the students, was remote. It provided a wonderful opportunity for the students to learn how to live without mains, water or electricity, how to handle patients at the dispensary when the nearest hospital was 80 kilometers away, how to get a first-hand feel of a largely subsistence economy. It was a radical approach to wholly integrated but equally rigorous clinical medicine. The program has changed, but if you go on the Ilorin University website, you will see it proudly trumpeted there. This always happens when you've got it printed out, you lose the place. And so I've now lost my place. I found it again. In order to ensure that clinical medicine in Africa is not taught as a purely bedside discipline, we realized that a textbook of medicine was important. But I want, first of all, before I show you that, to show you our students in a village, in actually a family compound. It doesn't project very well. But on the left is the health worker, and on the right are the students. Note the flared trousers. You can chronologically, you can date the picture by those trousers. And there they were, finding out. These were urban boys, the first time ever in a really rural environment. And they were supplicants trying to find out how people lived. It was transforming them. But they needed a book. They needed a book which embodied the sort of philosophy which we were trying to tell. So we produced this book, and this was the third edition, and now it's going into a fourth edition, and it'll be a low cost. We take no royalties, no one is paid anything at all in order to keep the price down in Africa. And Principles of Medicine in Africa is coming out later this year, and it's going to be, I hope, as widely used as it should be, if the teachers can get away from the idea of training students from Minneapolis and Manchester, which not many of them are able to do. In this book, we are quite radical. One of my contributors is Gustav Stick, a German who worked in Congo in sleeping sickness. And he says in this chapter, which he wrote, whether there will be more concern about the reality of sleeping sickness in Africa has to be seen as a question of scientific ethics and international solidarity. Our purpose in the book is to obliterate the dividing wall between clinical medicine and community health. If this is not done, clinicians will not champion the cause of the poor, and community doctors will retreat behind their computer screens. My final example of a clinician in public health is from a program of care for chronic disease in Ethiopia through THET, in which I've been engaged for over 15 years. You know what happens in an outpatient clinic. A physician sees a patient and says, please return after 1 month. and the computer's knocked out and the appointment is given, and they're to come back. For poor rural people in much of Africa, this drains dry their scanty flask of cash. The transport, a night's lodging and food, and the lost days on the farm. We therefore set about decentralizing care from the hospital to the health centre, where we now have specially trained nurses doing their everyday work, but additionally trained to care for chronic illness, and health officers doing their original work, but additionally trained to manage with the nurses diabetes, epilepsy, rheumatic heart disease, and more to come. I took that at an epilepsy clinic between a teaching hospital in northern Ethiopia and the Sudan border, the only clinic. We saw 100 patients that morning, and there is a nurse, a woman, and here is a nurse, a man. And they had been trained, and they were keeping excellent records. And at that clinic, one man had walked for 5 days to get there. Now that shows two things: that he really realized that the medicine he was receiving to control seizures in the member of his family who needed the medicine was effective. And that is a wonderful teaching of public health to a community, that it's possible to get Western medicine, which is good. And records are kept, and we're introducing now performance-related supplements to salary instead of the wasteful per diem arrangements for workshops at the central hospital. So in conclusion, I hope I've kept to my time. China in Africa, the story unfolds. And as a physician in Africa, I commend to you a broad approach to its health and disease. Thank you very much.